Hello, and welcome to the webinar, The Health of Lesbian, Gay, Bisexual, and Transgendered People, Ending Disparities, Ending Invisibility. My name is Melissa Da Silva. I'll be acting as moderator for today's webinar with support from Julie Hashida. Today's webinar is a production of the National Healthcare for the Homeless Council, made possible by a national cooperative agreement from the Bureau of Primary Healthcare and the Health Resources and Services Administration of HHS. This is a 1-hour presentation with the last 10 minutes reserved for Q&A. Again, thank you for joining us to learn more about this new National Cooperative Agreement recipient, Fenway Institute, and their TA and training expertise in LGBT health. Our presenter today is Dr. Harvey Makadon. Dr. Makadon is Director of the National LGBT Health Education Center at the Fenway Institute, a division of Fenway Health, a federally qualified health center in Boston. He is also a member of the Division of General Medicine at Beth Israel Deaconess Medical Center in Boston, where he has had a primary care practice for over 25 years and served as VP of Medical Affairs. He is Clinical Professor of Medicine at Harvard Medical School and LGBT Advisor in Harvard Medical School's Office for Recruitment and Multicultural Affairs. Dr. Makadon is the lead editor of the Fenway Guide to LGBT Health, published by the American College of Physicians in 2007. In addition to writing numerous articles and chapters related to LGBT health, he served on the Committee of LGBT Health Issues and Research Gaps and Opportunities of the IOM of U.S. National Academy of Sciences for the Health of LGBT People, Building a Foundation for Better Understanding, March 2011. Dr. Makadon was the recipient of the Community Service Award in 2000 and the Harold Amos Diversity Award in 2008 at Harvard Medical School, an Achievement Award from the Gay and Lesbian Medical Association, and the Michael Ty Leadership Award in 2004 from Fenway Health. Phew! Thank you, Dr. Makadon, and thank you, Jeffrey Walter, for your tech support. I now turn the mic over to Dr. Makadon for the beginning of this presentation. Thank you all again.
Thank you very much, Melissa and Julie, for organizing this, and thanks to the Homeless Healthcare Council for sponsoring this webinar. One thing that Melissa didn't focus on was that I actually am a primary care physician, so I don't want you to feel like all I do is sort of run around and give talks, but that what I'm really talking about is something that I learned kind of on my own through the years by taking care of patients. I started with an HIV practice and largely expanded my practice and began taking care of a lot of LGBT people, and a lot of the kind of issues that I'm bringing up come from my own personal experience, which I think is always important. And I hope many of you who are primary care providers out there will raise questions or your concerns concerning issues that you've been struggling with or managing over the years. Our objectives for today are really to talk about healthcare disparities which have been studied among LGBT people and some of the factors that influence these disparities, to identify strategies for taking a sensitive history with LGBT people and ending their invisibility in healthcare, to identify strategies for being supportive to people regardless of sexual orientation and gender identity, and also to talk a bit about the resources and training available from the National LGBT Health Education Center here at the Fenway Institute at Fenway Health. So a lot of people say, why are we talking about LGBT health? And a number of studies in the last couple of years, one from the Institute of Medicine and another from the Surgeon General through Healthy People 2020, have identified a number of disparities, and the origins of these usually occur in stigma and discrimination that is pervasive in our society and affects both people in general, but also is sometimes focused on individuals. Bias in healthcare towards LGBT people, which has been long-standing, as well as social determinants of health, particularly among people in the homeless population. When we look at the impact of stigma and discrimination, we see that clearly there have been instances of stigma and discrimination that have been highlighted in the past year. In the upper left-hand corner of this slide, there's a picture of a young man named Tyler Clementi, who was an undergraduate at Rutgers University in New Jersey, outside of New York City. He had an episode where he had sex with another man, and it was filmed by his roommate and broadcast on YouTube. And as a result of the humiliation he felt from this, committed suicide by jumping off the George Washington Bridge shortly thereafter. On the right-hand side of this slide is a transgender woman who, 6 weeks after reporting abuse to the local police, by the local police, was found killed in her community. And while there was no clear association, it was of concern that she had spoken out about the abuse she had received. Clearly, there are many instances of stigma and discrimination that people can probably relate to in their own communities. But even as things happen halfway around the world in countries like Iraq, where it is sodomy is illegal and people have been hung just for admittedly being homosexual, this certainly has a chilling effect on people, even here in the United States. People who are concerned about their sexual orientation or gender identity and wondering about whether it's safe to come out and be open about their sexual orientation. So I do think that we cannot underestimate the impact of stigma and discrimination as we think about healthcare disparities. We also have to consider the social determinants of health, which I know are things that you think about every day, taking care of homeless populations, but LGBT people cut across all racial, ethnic, and socioeconomic groups and experience disparities that are based on social determinants of health, just as others do. And we realize that being LGBT is not a separate minority group, but is one which overlaps with many different minorities, and people may experience much of the discrimination that is focused on other groups as well as specifically LGBT issues. The disparities which were highlighted in Healthy People 2020 were that LGBT youth are 2 to 3 times more likely to attempt suicide. They're also more likely to be homeless, which is why I know from the experiences of many of my colleagues and friends who have worked at Boston Healthcare for the Homeless, where I live, that they do see many LGBT youth in the context of their work there. LGBT populations also have higher rates of tobacco, alcohol, and drug use. Gay men in particular are at higher risk of sexually transmitted diseases and HIV, particularly among communities of color, and I'll say a bit more about this in a minute. Lesbians are less likely to get preventive services for cancer, partly because doctors are not sure exactly what risks they have. And lesbians and bisexual women are more likely to be overweight or obese. Transgender individuals, again, which I know are overrepresented in the homeless population, have a high prevalence of HIV and STIs. They're victimized frequently, have mental health issues, and often have higher rates of suicide. They're less likely to have health insurance than heterosexual or lesbian, gay, bisexual individuals, and therefore have difficulty accessing health care for this reason, as well as the fact that many healthcare providers do not really understand many of the issues related to transgender healthcare. Finally, elderly LGBT individuals face additional barriers to health because of isolation and a lack of social services, as well as culturally competent healthcare providers who really understand the need of LGBT elders. In terms of homeless LGBT youth, the National Coalition for the Homeless has published some information which I'm sure you're all familiar with, but I thought it's worth emphasizing that youth, once homeless, are at higher risk for victimization, mental health problems, and unsafe sexual practices. They're also more likely to have been sexually victimized compared to heterosexual homeless youth. LGBT youth are more likely to experience acts of sexual violence than heterosexual homeless youth, and they often commit suicide at about twice the rate of heterosexual homeless youth. So clearly, youth and homelessness are together issues which really increase the rate and the experience of healthcare disparities, and is something for those of you who are providers of healthcare in this population to be aware of and to think of ways to try and prevent. This slide represents very recent data from the Centers for Disease Control and demonstrates that although in the gray bars, the incidence of HIV in the country has been relatively stable, that the incidence among young black men who have sex with men or gay men between the ages of 13 and 29 has increased 48% in this relatively short time period, suggesting that this is a particularly important issue. And as a colleague of mine who is the director of a homeless healthcare center in the South said, we see lots of people like that, but we're not sure exactly what to do. So I do think it's worth highlighting it, and I think it's also important to recognize that this is an area where there needs to be a lot of attention and also a lot of research in terms of the best way to manage these issues and to prevent both sexually transmitted infections as well as HIV infection. Clearly, the benefits of reducing disparities occur across the different kinds of health experiences people have: non-communicable diseases, communicable diseases, and behavioral health issues. So both medical and mental health issues, where we would see reduction in disease transmission, increased mental and physical well-being, reduced healthcare costs, and increased longevity and resilience, and the ability to lead kind of long, happy, healthy lives. So I do think that working with people on these disparities can help them in many different ways. And as clinicians, I do think we have an important role to play in this area. What I wanted to turn to now was, having gone through some of the disparities, to sort of talk about how we translate what we know into higher quality care and a positive experience for individuals wherever they receive care. Clearly, we know we need to do more research to learn about this population, but even given what we know, how can we educate one another, provide better care, and make care more accessible so that people can eliminate their disparities and feel like it's okay for them to be themselves in whatever setting they're living or working in. We start off by getting to know our patients. So one of the issues that faces every clinician is when someone comes in, how do you know whether they're a new patient or a new gay patient or a patient who may be a man who has sex with men but not identify as gay? And then how do you feel when learning this? Because I know a lot of clinicians often feel reluctant to ask questions of an intimate nature, partly because they're not sure exactly what to say to somebody if they get an answer that they feel uncomfortable with. So I think it's important for us to examine our own feelings about LGBT individuals and think about what it would take us to feel more comfortable having a conversation. So because of this, I wanted to spend a little time going through terminology related to lesbian, gay, bisexual, and transgender people. And I specifically separated the traditional LGBT into 4 separate letters because each of these populations is different from the other, and within each, there's a great deal of diversity that we need to take into consideration. In the past, we had a tendency to think of all gay people as the same. This is one of my favorite cartoons from an old issue of The New Yorker where this woman runs into these two men in the supermarket and they say, no, we are not twins. But we've learned that there's a great deal of diversity in the LGBT community. And when we look at the different kinds of people that we read about, see on television, meet in the course of our work or home life, we realize that there really is truly a diversity of expression both in our own communities and around the world. And it's important for us to keep this in mind, that there is no one stereotype or one way that people will look to us, and that we really know nothing about someone until we've begun to ask them questions about their lives. As we do this, it's important to think not just about understanding someone's sexual orientation, but to think about the components of sexual orientation. So first is, how does someone identify? Second, what kind of behaviors do people engage in? And finally, there may be people who have not engaged in any behaviors with other people, but are attracted and have desires that they may not have ever acted on, but would like to. And as clinicians, we can be very helpful for those people if we ask them about these issues and help them explore their feelings and concerns so that they can actually kind of feel better about themselves. And we can spend some more time talking about this later. But the disparity and the discordance between sexual behavior and identity has been demonstrated both in men and women. In a 2006 study of men in New York City, it was a mental health study, but 9.4% of men who identified as straight in the initial questions in the study also admitted that they had sex with a man in the prior year. So again, highlighting the fact that there's a discordance between how people identify themselves and how they behave. Now, these men were more likely to belong to minority racial and ethnic groups, be of lower socioeconomic status, be foreign-born, and importantly, not use a condom when they had sex. And then also among lesbians, a vast majority had had at least one prior sexual experience with men, and 8% had had one in the prior year. So again, while someone may identify as a lesbian or someone may identify as straight, we can't assume that their behavior is entirely consistent with that. And it's important to ask about all of these issues. Another point I wanted to make is that the data from the most recent census, which was analyzed by the Williams Institute in Los Angeles, showed that same-sex families exist across the country. And while the highest concentrations are where we would expect on the east and west coast and in some areas in the middle of the country, there's that same-sex families identified themselves in the census in 99% of counties in the country. And again, this is probably an underrepresentation, first because people voluntarily reported this information, and secondly, it only asked about same-sex headed families which were headed by same-sex couples, as opposed to asking whether there were individuals who identified as gay, lesbian, bisexual, or transgender living in a household that might be headed by a heterosexual couple. So again, it undercounts the number of people, but does demonstrate that same-sex families do live almost everywhere in the country, and wherever we practice, we can expect that we might see people from same-sex families and same-sex couples. When we look at LGBT demographics in the United States, the numbers vary, with higher numbers being in urban areas and lower numbers being in rural areas. But if we look at the percentage that identify as lesbian, gay, or bisexual, they range from 1.4 to 4.1%. When we ask about same-sex sexual contact in the last year, it ranges between 3 to 4%. And same-sex sexual contact ever it ranges between 4 and 11% among women and 6 to 9% among men. One area that people often find a bit confusing is understanding the term transgender or understanding the T in LGBT. And I think there's good reason for that, and that is that it's a complex area. The terminology has changed considerably, even in recent years, and there's a great deal of fluidity in terms of how people describe themselves and what terminology they'd want to use. So it's important to keep in mind that gender nonconformity refers to the extent to which a person's gender identity differs from cultural norms for people of a particular sex. And the terminology is culturally and time dependent, and as I said, is rapidly evolving, so that the terms people use may change from 1 month to the next or 1 year to the next. I think the largest areas that we need to concern ourselves with as clinicians are first understanding that transgender, which was an umbrella term to describe many different types of individuals, is now really associated more with people who persistently identify and or express their gender as the opposite of their biologic birth sex. These people often have hormonal and surgical treatment, and in this case are more likely to be called transsexuals, or this is called transsexualism. Some people like to use this term, some people don't like to use this term. But again, transgender people generally identify as the gender opposite their biologic birth sex. There's also individuals who define themselves as a gender outside of either or the construct of male or female. That is to say, they see themselves as having no gender in particular. They might think of themselves as androgynous or having elements of multiple genders. And some people use the term bigender or genderqueer. This may seem like something that people have not heard of, but particularly those of you who work with younger people and adolescents probably hear this more and more, as I think a number of people don't really see themselves as identifying as male or female, or at least go through some phase of their life feeling this way and might express themselves this way. So it's something for us as clinicians to be aware of. And that some people often enjoy just the outward manifestations of gender roles and cross-dress to varying extents, wearing clothes of the opposite sex, but not necessarily identifying themselves as people of a gender opposite to their biologic birth gender. So these are all different, as we say, gender variants, but not necessarily something that are related to each other, but different manifestations of the way gender identity can be expressed differently. And again, something for us all to be thinking about when we see patients and have conversations with individuals. Which gets us to the issue of taking a history from our patients. These slides really relate to discussions with HIV-infected individuals, and I included them here only to highlight the fact that in this study, a proportion of physicians discussing certain topics with HIV-infected people, 84% were likely to talk about use of medication, in this case antiretroviral therapy or ART, but only 16 to 14% discuss condom use or HIV transmission. That is to say, it was harder for people to talk about more intimate issues than it was to talk about the more familiar issues for clinicians like adherence to medication. The Institute of Medicine sort of picked up on this, and in the report, The Hidden Epidemic in 1997, said, ironically, it may require greater intimacy to discuss sex than to engage in it, recognizing the difficulty that clinicians face when having conversations about sexual orientation or gender identity with their patients, and underscoring the need for us to be thinking about how we can improve the education of health professionals in this very important area. When I think about teaching about this, I tend to think about it in terms of the theory of cross-cultural care. A lot of people would refer to this as trying to help doctors become culturally competent. That's a term that I often found somewhat overwhelming in the sense that I often felt that I had to know absolutely everything there was to know about somebody to feel competent. But I think doctors should feel comfortable asking people questions as long as they're based in real curiosity and they ask their questions respectfully and empathically. And while some patients may be surprised by certain questions regarding intimate issues, if you ask the questions in these ways, generally people can be understanding, particularly if you contextualize the questions and explain why you're asking them. So in terms of taking a history, the core comprehensive history for LGBT patients is really the same as it is for all of our patients, keeping in mind the unique health risks that we've gone over earlier in this talk. But what we want to do is get to know our patients as a person, learn about their partners, their children, their job. And for some patients, it may be very easy just to simply ask a question like, tell me about yourself, in which case people may talk about their sexual orientation or gender identity. And I might do this in a situation where a patient came to me with no other medical concerns, but just for a routine visit. It's important that when we do talk to people and don't know very much about them, that we use gender-neutral terms and pronouns when referring to partners, particularly when we don't know about their partners. So we might say, do you have a partner or spouse? Are you currently in a relationship? And what do you call your partner? Rather than using an assumption that if you're seeing a man, you refer to their partner as she, before the patients had an opportunity to sort of talk to you about who they're involved with or whether they're involved with anybody. It goes without saying that we have to avoid judgment and bias and assure confidentiality, asking permission to include sexual orientation and gender identity in the medical record. And be sure to be aware of, as I said, evolving terminology such as queer, or the fact that some people prefer same gender loving to gay as a way of describing their relationships. This is a term that's particularly used among African American men. As I said before taking a sexual history, it's important to explain that this is something that's routine and confidential, and that you're really talking about both sexual health and risk, that there's some things that you ask all of your patients, and that you want to assess individuals' comfort with sexuality by asking something like, do you have any concerns or questions about your sexuality, sexual identity, or sexual desires, which again may open the door for somebody talking to you about concerns they have about their sexual orientation. In terms of gender identity, it's also important that we ask people about this. It's probably even a little bit more uncomfortable sometimes than asking about sexual orientation, but it gives people an indication that if they do have concerns about gender or gender issues, that they should feel safe talking to you about it. So you can say something like, because so many people are impacted by gender issues, I've begun to ask my patients if they have any concerns about these. Anything you say will be kept confidential. or I ask clients what gender pronoun they prefer, I use for them, and what pronoun would you like for me to use with you. Again, sometimes this may seem a bit uncomfortable, but for many patients it's going to be very important. And given the fact that there is a relatively high prevalence of transgender people in homeless healthcare, there are issues that have to be seriously thought about and considered. Finally, I think we have to understand people's desires where they may not have had any sexual behavior with another person, and figure out how we support them for coming out if that's what they want. Again, it's important to remember that people can come out at any age regarding both sexual orientation or gender identity, and that it's important to ask people who are coming out if they have family and community supports, which are going to be very important for them, or if they have concerns about how their family is going to react when they begin talking about these issues with them. Because this, again, is an area where clinicians can be very helpful at working with people over time, not necessarily in one visit, to help prepare them for having conversations with close friends or family members who they are concerned about. In addition to what we do in clinical settings, we have to think about what we need to do to create change at home where we work and create better environments for caring, learning, and working. So in terms of the environment where you currently work, think about if you know whether LGBT patients feel welcome and safe to disclose their sexual behavior and identity. Have any surveys been done of LGBT people to see how they feel about the place where you currently are seeing patients? Similarly, it's important to understand how people working there feel. Do you know if LGBT staff, clinicians, students, and trainees feel safe and accepted? Because I think if they don't, that's going to make it harder to create an environment that's welcoming for patients as well as staff. Do people feel comfortable being themselves? Do people you know who you work with feel comfortable talking freely with their colleagues about their home lives and who they are? Are staff and professionals being taught about LGBT health needs? Often I would just take a pause here and ask a question about, how people feel their institution is doing, but you might think about it yourself in terms of whether people feel comfortable where you're currently working. And then, is there an organizational structure to adjudicate concerns? If students or staff feel as if they're hearing things that make them uncomfortable or make them feel somehow harassed in the workplace, is there someone that they can talk to about that? And is there someone who will take these concerns seriously? The Joint Commission, which I know you all know about, has recently published a field guide on advancing effective communication, cultural competence, and patient and family-centered care for the lesbian, gay, bisexual, and transgender community. We don't have time to go through this field guide now, but this is something that you can download from the Joint Commission website. And I highly recommend that particularly people who are responsible for running programs or administering community health centers look at carefully, because these issues in the field guide are likely to become Joint Commission standards in the years ahead. And they range from requiring non-discrimination clauses in the Patient's Bill of Rights to, and the mission of the organization, to collecting information about sexual orientation and gender identity from patients when they come to get care. So again, I think it's very important to pay attention to this, which leads us to think about the patient environment, because there are many things in the environment that can give signs to patients that they can feel comfortable being themselves and talking about their sexual orientation or gender identity, or they may feel like there's no indication that that's the case. So think about what it would take to create intake forms that ask about the full range of sexual and gender identity, ensuring confidentiality in forms, training staff to be respectful of LGBT clients and to use clients' preferred names and pronouns. As I've mentioned, post non-discrimination policy inclusive of sexual orientation and gender identity openly, and don't just keep it in a policy manual. Display images around the health centers that reflect LGBT lives and what people can relate to. So posters with pictures of same-sex couples, books, brochures on the health care of lesbian and gay patients or transgender patients, images of rainbow flags or transgender symbols, and offer unisex bathrooms so that people who do have concerns about or have gender identity issues or are transgender feel that they can comfortably go someplace and not have to worry about which restroom to use when they need one. But these are very important signs also to individuals that you do care about creating an environment that is welcoming for people regardless of sexual orientation and gender identity. In closing, I wanted to spend a couple of minutes talking about the National LGBT Health Education Center located here in Boston at the Fenway Institute in Fenway Health, which is a health center that was founded in the 1970s. Our foundations are that Fenway Health was founded in, as I said, 1971, and currently cares for about 15,000 patients who are HIV infected. The mission of Fenway Health is to enhance the well-being of the LGBT community, as well as people in our neighborhoods and beyond, through access to the highest quality healthcare, education, research, and advocacy. And on the right-hand side is a photograph of our wonderful new building where we're able to house both the clinical care areas as well as the Fenway Institute where the education center lives. The Fenway Institute was founded only in 2000 and is a focus of research and evaluation. We have 61 active research protocols. Many of these are about HIV care, but many of them are also about HIV prevention, using both outreach in the community as a way of prevention, but also looking at biomedical methods of prevention such as post-exposure and pre-exposure prophylaxis with antiretroviral therapies. We do advocacy and policy on issues related to healthcare. We have a population research center to look at what we can learn or what we can do to learn more about LGBT community health needs. We house the Network for LGBT Health Equity, which has focused in the past on smoking and the high rate of smoking in the LGBT community, but now has expanded to other areas. And finally, the National LGBT Health Education Center, which, as Melissa said when she introduced us, includes the National Cooperative Agreement to work with health centers across the country on LGBT health issues, both in terms of training clinicians, but also technical assistance. Our foundations for the Education Center were that we wrote the Fenway Guide, and this is a photograph of the guide that Melissa mentioned. This was the first medical text that focused on the care of LGBT people, and we've now developed some online learning modules which we have on the Fenway website, but which are also in the process of being updated into a new website for the National Center. We've done Grand Rounds series on LGBT health in conjunction with the American Medical Association since 2009, and I'm pleased that today we found out that this program will be extended for the next couple of years, so that we're happy to come and give grand rounds to mostly academic medical centers, but also community hospitals. And we do multiple other trainings, technical assistance to both hospitals and health centers. So we feel as if we have a fairly well-rounded program, but we are in the process of sending out a needs assessment to many constituencies of health centers and primary care associations to learn what people really want to hear from us and how we can be most helpful at caring for lesbian, gay, bisexual, and transgender people. This again highlights the National Cooperative Agreement. We're trying to do our trainings through national conferences, webinars, primary care associations, regional meetings. We're going to be providing our own online CME programs such as this in the future. Those will probably start in the fall. And our target audiences, as I've said, are clinicians, administrators, and support staff. And below on this slide, which will be posted on the website, are some of the sample topics, which include both clinical issues as well as administrative issues, ranging from how to collect information on patients to how to work with your board on understanding issues around lesbian and gay health. Finally, I wanted to say that we're very pleased that the National Healthcare for the Homeless Council has invited us to speak at their national conference this year in May in Kansas City. And our talk is going to be on how to optimize the care of lesbian, gay, bisexual, and transgender people. This talk will be a more advanced version of what we've been able to do today in a relatively short period of time, which we view as an introduction to these issues. But we are going to have time for some questions and answers in a minute. And we want to invite you not just to ask your questions online here today, but to feel free to communicate to us directly, either through the Homeless Council or directly to us at the Fenway Institute. So we look forward to answering your questions, to hearing from you in the future, and hearing about both how we can help you and what kinds of questions you have that you find would be helpful for your organization. I really wanted to thank Melissa and Julie again for all they've put into making this webinar possible, and to Jeff Walter, who's here helping organize things at this end. And let's begin getting to the questions that you've raised. Thank you very much. Oh, there are on the slides listed some resources that are available to you so that you can look them up, including the Joint Commission website, as well as information from other organizations that we thought would be helpful.
Thank you, Dr. Makadon, for that wonderful presentation. We actually have 3 questions for you. And so I landed on you just to direct our attendees to our homepage at www.nhchc, where under latest news, you'll see a link to Fenway Institute's Needs Assessment Survey. And we will also have this PowerPoint archived on our website within 72 hours, just a reminder. And now for our first question to Dr. Makadon. This comes from Louis. Louis asks, what is your advice for shelter staff in managing transgender clients' use of sleeping and bathing spaces at the shelter? And I believe, Dr. Makadon, you alluded to this on your patient environment slide. So, Mike, back to you, Dr. Makadon.
I think this is a very good question. And as I said, these issues are complex, and I think the more we learn about transgender people or people with various gender variant or gender issues that they're concerned about, I think the more we learn that it's best to have some space that isn't identified as male or female so people can use it and feel comfortable. I know that not all health centers can readily do this, But in terms of planning space for the future, I think it is what would make people feel most comfortable, and also gives people an indication that you're thinking about them so that they feel comfortable coming there for care, for sleeping, for bathing, and for anything else that they need, any other resources they need from the health centers.
Thank you, Dr. Makadon. Our next question comes from Matthew, and Matthew would like to know, are you aware of how health centers deal with issues surrounding LGBT homeless youth who are minors and technically require parental consent for care and other procedures? Mike, back to you, Doctor.
Matthew, that's a very good question. I do think that I'm actually an internist and I take care of adult patients. At the homeless session that we're going to be having at the annual meeting, we are going to have a physician from our adolescent program to deal with issues just like this. I think sometimes it's very difficult to be in a position of being a clinician taking care of someone, particularly when they're very close to the age of consent, in order to be able to do things, in order to be able to kind of give them appropriate advice. And I think it would probably be good to wait until then to be able to respond to these questions.
Thank you, Dr. Makadon. And we have a question also now from Sydney. I hope I'm pronouncing that correctly. Sydney is actually interested in examples and or resources for data collection tools to reflect LGBT identity, relationships, etc. I think you alluded to this on the training topics slide, so maybe just a reiteration. Mike, to you, Dr.
Yeah, I think that, this is actually an extremely important question. Here at Fenway, we actually have been doing focus groups and studies of our patients to understand the best way to do data collection. Well, let me just say, I think the best way to do data collection is to have a conversation with your patients. But that doesn't necessarily allow you to kind of look at a large collection of data and do research unless people ask everything in a standardized way. So what we've been doing is studying our patients and learning what kinds of questions make them feel most comfortable. And we've done this now with respect to sexual orientation, and we're in the process of finishing a project among transgender patients. But on our the form we use in our electronic health record, we now have a question regarding sexual orientation where we ask whether people would like to be referred to as, and I don't have it in front of me now, but it gives people options. So they can say they're heterosexual or straight, homosexual or gay, bisexual, but then gives an opportunity for people to say other and I don't know, so that we give a standard selection of questions, and based on that, we feel that we'll be able to go back and look at the kinds of care people get based on the kinds of answers they get, the answers they give to those questions, to make sure that everybody is getting the appropriate care and that there aren't any disparities in care among different kinds of people coming to the health center, or people who identify themselves differently who come to the health center. This is unfortunately something where there's no one national standard on how to do this, but that I think that there are a lot of people in the Department of Health and Human Services who are working hard on trying to think through what would be best practices in terms of how to do these kinds of things. And then on a broader level, the Institute of Medicine report did ask the National Institutes of Health to do this for research studies, and in addition to also include more lesbian, gay, bisexual, and transgender individuals routinely in research studies so that we can learn more about these populations. I hope that answered your question, and I'm turning this.
Thank you, Dr. Makadon. That actually concludes the questions we'll be taking for today's presentation. So right now, I'd like to again thank Dr. Makadon and Fenway Institute and Jeffrey Walters so much for this terrific presentation. I'd like to bring your attention to our resource slide. Again, it lists our address. It has additional information about the upcoming national conference, the workshop that Fenway Institute will be presenting. And also, there's a bullet there for a one-day training event with Fenway Institute here in Nashville, Tennessee on June 29th, 2012. If anyone's interested in attending that one-day training, please email us. You can email you can email anyone on the TA and training site or mdasilva@nhchc.org. That's going to come up for you under your Q&A, in your Q&A chat box in just a second. Also note that we have links to our technical assistance and our webinar page. Thank you all again for joining us today. Don't hesitate to reach out to us by email or phone. And I think that's it. Happy trails.